Okay, let's dive right into a pretty wild medical paradox, a condition where a problem in your liver ends up creating a life-threatening issue for your lungs. It's this complex connection that turns standard medical treatment into a real high-wire act, and we're going to break down exactly how that works. The name itself, Portopulmonary Hypertension, tells you the whole story. It's like two conditions tangled up into one dangerous diagnosis. You've got porto for portal hypertension, basically high pressure in the veins of a sick liver. And then you have pulmonary hypertension, which is high blood pressure, but specifically in the arteries of your lungs. This condition is where those two worlds dangerously collide. So the big question is, how on earth can a struggling liver do damage all the way over in the lungs? It's not like they're touching. Well, it all comes down to a dangerous detour that your circulatory system takes, one that bypasses a really critical checkpoint. Okay, so here's the chain reaction. First, you get liver disease, something like cirrhosis. It creates a massive traffic jam, and the pressure in that main portal vein just skyrockets. Because of that backup, the blood is smart. It finds a new way around, a bypass that completely skips the liver. Now here's the real problem. Your liver's job is to filter all sorts of stuff out of your blood, including these things called vasoactive substances. With a bypass in place, those substances just flood your system unfiltered. They travel right to the lungs, and that's where they cause the arteries to clamp down, to constrict and get damaged. You can think of the liver like a city's water filtration plant. If it breaks down, all that unfiltered gunk goes straight to the very delicate pipework of the lungs. Now, what's so fascinating about this is how clinicians even find it in the first place. This is a stealthy condition. Its symptoms are really good at hiding in plain sight because they often look just like the symptoms of the liver disease the patient already knows they have. And that's the absolute core of the challenge. A patient comes in, they're tired, they're short of breath, and everyone thinks, well, of course they have liver disease. But is it just the liver disease? Or is it this other, much deadlier problem brewing in their lungs? The first clues are incredibly subtle. So to figure this out, doctors have to be detectives. They combine what the patient is feeling with what they can physically find. So yeah, the patient might say they get out of breath just walking up some stairs, but during the exam, a doctor might hear a really specific accentuated heart sound, the sound of the pulmonary valve slamming shut under all that pressure. They might also hear other murmurs, which are all clues that the right side of the heart is really straining to push blood into those tight lungs. So the hunt usually starts with a wide net, a screening tool called an echocardiogram. It's non-invasive, it uses ultrasound, and it can give a pretty good estimate of the pressure in the lungs. But an estimate isn't enough. To get the final definitive answer, there's really only one way, and that's a right heart catheterization. It's more invasive, yeah, but they actually thread a tiny catheter right into the heart and pulmonary artery to measure the pressures directly. It is the only way to know for sure. So this isn't a guess. The diagnosis is official only when you hit 4 very specific targets. First, the main pressure in the lung artery has to be high, over 20. Second, the resistance in those lung vessels has to be up. Basically, the pipes are too tight. Third, what they call the wedge pressure has to be normal, which tells them the problem isn't coming from the other side of the heart. And finally, of course, you need to have that confirmed portal hypertension from the liver. You have to check all 4 of those boxes. Okay, so let's get into treatment because this is where things become one of the most high-stakes balancing acts in all of medicine. You see, you have to treat the lung problem, not just to help the lungs, but to even have a chance at fixing the liver problem. And get this data is pretty startling. If you look at patients with PUF, their 5-year survival rate is only about 40%. That's way worse than the 64% for people who have pulmonary hypertension from an unknown cause. But here's the paradox. The POF patients often have better-looking pressure numbers when they're first diagnosed. So why do they do worse? It's because that underlying liver disease actually masks how severe the lung problem really is, all while adding this whole second layer of risk. It's a double whammy. And that brings us to the entire goal of the therapy. The only real fix for the root cause is a new liver. But you absolutely cannot do a liver transplant if those lung pressures are sky high. The stress on the heart during the surgery would be fatal. So doctors are literally in a race against time. They have to get the lungs under control to make the liver transplant survivable. To pull this off, they use a very specialized arsenal of medications. We're not talking about your everyday blood pressure pills. No, these are targeted therapies. Things like endothelin receptor antagonists, PDE5 inhibitors, and prostacyclin analogs. They all work in slightly different ways, but they have one shared mission: to fight back against that constriction, to relax and widen those clamped down blood vessels in the lungs, and bring that pressure down. And all of those powerful drugs are aimed at hitting one single critical target. This is the golden number. The mean pulmonary artery pressure, or mPAP, absolutely must be brought down below 35. That's the threshold a patient has to cross to be considered safe enough to get the green light for that life-saving liver transplant. This quote really just says it all, doesn't it? It spells it out in black and white. If you fail to control the high pressures in the lungs, the chance to fix the failing liver is gone. The transplant is off the table. The lung condition completely dictates what you can do for the liver. But even with all these amazing treatments, PoPH is still a really tough field. The progress has been incredible for sure, but doctors and researchers are still navigating a landscape that has a lot of unanswered questions. You know, what this really shows is that the medical community is still trying to fine-tune the rule book here. There are some big questions left, like what's the best way to handle these therapies after a successful transplant? Is that pressure cutoff of 35 too strict, or maybe not strict enough? And how can we get better at predicting which patients are at the absolute highest risk? To answer that, we need more data, which is why a lot of people are pushing for a national registry to track how these patients do over time. And that brings us right back to the central paradox of portopulmonary hypertension. It's a two-organ problem, a sick liver and damaged lungs, but the cure for one organ completely depends on getting the other one under control first. It is a delicate, incredibly high-stakes medical puzzle, leaving both patients and their doctors navigating one of the most complex journeys in all of modern medicine.